That's confirmation. That's correct. Yep. Zip code and send. If you're getting a message back asking for your zip code, that is correct. That's how you authorize. You need to enter your zip code, and that authorizes the transaction. It'll appear on your phone bill. Got it. Thank you. That's great. Yes. Okay, before everybody leaves, I just want you to know that as you are texting to donate, somebody just told me that they're going to add $1,500 on top of the $2,000 match. So now we have $3,500 coming on top of what you're donating. So thank you to those two individuals who chose to do that. We have a few more minutes here, and the doors are closed because we're not allowing anyone out until we know that everybody is texted to donate. I've been watching. We have about 43 more people, so you know who you are. Have most people finished they go through?
Our settings are too high on our AT&T list, and they're
Thank you. I still see some phones out. Oh. Online you can do it, but yeah, anytime. Sure, great. Okay, all right. I still see people working on their phones. I think they're looking at other things on their phone. They're no longer texting the TMA. Somebody else just gave a check. Someone gave some cash. We take anything. Anyway, all right. Thank you very much for everybody's support. It all goes to a worthy cause, which is you. And the next sessions begin in about 5 minutes. We'll see you back here tomorrow morning for breakfast. And by the way, I just got a text from somebody. I thought it was that they didn't know how to text to donate, but instead it's that they're going to give $1,000 as well. So we're now up to $4,500 on top of whatever's been given. So thank you.
Got it. This right here, so that big green button at the top is going to go forward. Laser pointed down here, go back with that button.
Got it. Hey, Bob. Should I get started? I mean, it's after 2. I don't want to. Okay, if we could try to get started here because we're going to have to finish at 3:30. Bob, it's 3:30, correct? Oh, it's 4. Okay, that's fine. That's fine. But I'll have to leave right at that time at 4. I won't have much time afterwards. So, farther? All right. Too loud? This is good? Okay. Okay, I suppose whoever wants to be in here is in here? Okay. I'll get started. My name is Chad Oddis. I'm from the University of Pittsburgh, as you see there. I direct the Myositis Center there, and what this session is referring to or going to discuss are medications. And I usually do slides, but and usually the room is smaller. And there's a lot of interruption during the slides. Should I, during the session, are we able to allow questions during the session itself as opposed to at the end? Is that okay with you guys? If we have the mics, and is anybody here from TMA that can hand the mics around? I usually think it's better to allow interruptions during the session itself. So there are a couple microphones over here. Okay. So how about if I get started here? And you know, like I said, sometimes it's better if you want to ask questions and raise your hand in the middle. That's the way I've done it before. I can run through the slides and we'll see which way it goes here, but let's just get started. So we're required to put up our disclosures. And I just thought I'd go through some general concepts in terms of treatment. And remember, this is, you know, I see patients with IBM, I see patients with all types of myopathy, but, you know, most of these treatments are in regards to polymyositis, dermatomyositis, because we don't have great treatments for IBM, you know, as you've heard many times before. So most of these therapies that I'm going to talk about are really in relationship to the data that looks best in terms of the responses that we get. So first of all, just some concepts. You know, these diseases, you've heard the term, they're inflammatory and they're autoimmune. And because they're inflammatory and they're autoimmune, they tend to portend a better response. Now, the drugs that we give will basically, therefore, decrease inflammation, and they will also suppress the immune system because of the inflammatory and the autoimmune component. Now, what we've done over the years is we've borrowed from oncologists. Why? Because a lot of their drugs also suppress the immune system, and they're chemotherapeutic agents, but we use those in lower doses than the oncologists generally use. So we're talking about medications such as methotrexate, Imuran, Cytoxan or cyclophosphamide, and rituximab even. And we'll talk more specifically about these medications as they arise later on. Now, the other thing is we actually now borrow medications from the transplant surgeons. And why do the transplant surgeons have medications that we use? Because they have to prevent the body's attack on an organ that is transplanted, right? So therefore, they also need medications that suppress the immune system. Therefore, there are medications that they use that we now use. And those are listed there, and we'll talk about those as well. So those are the general concept, and this is the general breakdown of the medications that we use. You'll see right off the bat, and I hope, well, if they're not now, these slides will all be made available to you. Again, they're geared for patient education and not really geared for lecturing to other doctors, although a lot of the slides are somewhat similar. So the point is here that we have different classes of medications, okay? The first major class are the glucocorticoids or steroids. The second one are immunosuppressive agents, and you can see the list there. And I want to move on kind of in order, and we'll talk about them as we, you know, as we move along. So the first medication on the list, and everybody knows about steroids. You know, they're good. They're a two-edged sword, aren't they? You hate them, and sometimes you need them. Okay, so there's no question about the need for steroids. So again, this is taken. I can't read it very well from here, but what I thought I'd do is kind of make these available so that you can see, well, okay, that's the list of medications, and these are the doses that we oftentimes use, and this is the level of evidence, and we'll come back to that. And what you're going to see as kind of a recurring theme is there's not a great level of evidence that we have for these medications, but we certainly know that steroids work. Oops. And they work in doses that are quite variable. In fact, when I lecture to the medical students at the University of Pittsburgh on steroids as part of their first and second year of medical school, and we use what's called a problem-oriented approach. In other words, if you've got a rash or if you've got joint pain, we don't give you 60 milligrams of prednisone to treat that particular feature. We may give you 5 or 10 or 15 milligrams. But if you've got very active myositis with an active inflammatory component, then we indeed do use the higher doses of steroids that are listed on that slide. So that's the steroid component. I'm not going to talk about all the mechanism of action, but the point here is that these steroids are very potent anti-inflammatory medications that suppress the inflammatory component and also attack the immune component. So they go after those immunologically active cells that are attacking different parts of your body. Now, this isn't meant for you to read. It's meant for you to actually see the side effects and also to see on the right side of this, the level of evidence that we have in a big, and I'll come back to this on many times. And again, I can't read it here, but the two red bars, if you want to go over these slides on your own, the two red boxes, this is steroids and this is the side effects. And the point that I also want to make here is that is a very small box. And when I talk to the students about the side effects of steroids, it's voluminous, okay? What are they? You gain weight, it raises your blood pressure, it makes your face puffy, it causes you to retain fluid, it causes your bones to get weak, it predisposes to infection, okay? It causes, in some cases, mouth ulcers and cataracts. I mean, the list goes on, okay? And that's why there's no better example in medicine these days from a medication standpoint of a two-edged sword than steroids, okay? So again, that is a very short list. Well, I grouped two together, and that is immune suppressive medications, and the second one is combination, because we use combinations of medications. What do oncologists do when they treat malignancy? Well, they use different combinations of medications, and we do the same thing. So it's obviously anybody in here who has polymyositis and dermatomyositis probably has had a combination of steroid with at least one other of these agents. And these agents include a whole list of things, which I'm going to go through. But they are called immune suppressive, and they may have the same effect of steroids, but they act in a different fashion. That means they have a different mechanism of action. So how do we make that choice? And again, I put up here some strategies, okay? Medications after prednisone. Everybody knows about prednisone. Everybody knows about steroids, all right? So what do doctors choose? Well, oftentimes before going to any other medication, they are going to try steroids first, all right? And that's because we get a good response and we get a fairly rapid response, okay? And the second point that I try to make, and it's points 2 and 3 there, is that usually, in most instances, for cost purposes, for effectiveness purposes, the next medications on the list include methotrexate and azathioprine, or methotrexate and Imuran. Okay, that's the other name. All right, and they're usually given in a sequential fashion. And I also wanted to make a point that I put them both up there on the same slide because these are sometimes given together as that combination regimen, and I've done that in many instances. Okay, so that's the medications after prednisone, and what's the rationale? Okay, well, the rationale includes published studies, what some of the people that were sitting up here earlier and others before us have put into the literature on results. Okay, the second thing is it's the experience of the treating physician. So what am I comfortable with, which may be different from what a neurologist is comfortable with. Okay. So that's the challenge sometimes when a patient goes to a doctor. You get different, sometimes mixed messages from different doctors. But the point is, it's both art and it's science. The science part of it comes from the studies, but the art part of it does come from what the doctor is comfortable with. Okay. And then there's a little bit of a difference, rheumatology and neurology, okay? We are a little bit more comfortable with methotrexate and Imuran, actually, whereas the neurologists now, they're coming around because they've used these medications for other diseases. And they're comfortable in the beginning more with azathioprine, but again, they're using methotrexate as well. So the next two, expanding the chart that you can, again, look at later at your leisure. We've got the dosages here. Methotrexate is kind of a nice drug because it's got some flexibility. It can be given orally. It's only given once a week. We don't give it on a daily basis. You can take it by injection as well. So before I sometimes call that drug a failure, I will administer it by injection. And I will often go, as you will see there, up to the 25 milligram weekly dose. But many times it is very effective from an oral perspective. You take, start off at 4 tablets. You might start off at 6 tablets. You work up to 8 to 10 tablets a week. and then you assess the effectiveness over a defined period of time. Now, if there's no response, do we give it for a year? Well, probably not. We're going to make a decision after a period of maybe 3 to 6 months, okay? And the same thing with Imuran. It's a matter of starting at a lower dose and increasing that dose maybe up until 150 or 200 milligrams a day. And as you could guess, the next slide I'm going to talk about is the side effects, all right? And I've listed them there, and I put a box around it. Again, if you want to look at it later on. Again, from a big review article that Rohit and I wrote a couple of years ago that's fairly up to date. Well, side effects from methotrexate, people get mouth ulcers. We tell them you can't drink very much alcohol when you're on that. Occasional glass of wine, maybe that's okay. But the trouble with methotrexate is that it can have some liver problems. So we cut back on the alcohol use, or we cut back on the other medications that are being used that can also affect the liver. So you can get mouth ulcers, you can get skin rashes, you can get elevated liver tests, you can have a predisposition to infection. Why? Because this medication suppresses the immune system. Imuran has a little bit different pattern of side effects, but you can see there that you also have to monitor the liver tests there, and you can suppress the bone marrow. Remember, these medications, as I said earlier, they can all potentially lead to infection because you're fighting the autoimmune attack on your tissue, but you're also preventing those same immune cells from potentially fighting infection. Now, is there an outrageously increased frequency of side effects of infection? No, not necessarily, but nevertheless, enough that we have to be concerned about it. Okay, most of you guys that have been treated know about methotrexate, prednisone, Imuran. What about beyond these medications? And I can tell you right now that a lot of those physicians still struggle with treating patients beyond steroids, including everyone that was up here on this panel today, because there's not a lot of data, okay? And it does boil down to art, science, and what we're comfortable with. So we look at the published studies, and the point I want to make, and I put a big box around it now, is look at the level of evidence that we have there. And now you guys aren't doctors, and you're not scientists. But if you look at a lot of things, it says case reports, case series, you know that there's not a whole lot out there that allows us to make very informed decisions. So we've got a paucity, a lack, a real need for more data. And I just kind of outlined that in this very large slide that again can be looked at. So what do we have then? Like I said before, we have very few what are called controlled trials. That is, trials that are done in a prospective fashion after good planning. A lot of the studies that we have to look at are doctors going back, much like you guys asked about this morning. Well, go back and look at this. We'll go back and look at that. Well, that's okay. But when you go back and look at something, it's not as well controlled. You don't have good, timely, longitudinal, that is, follow-up data on things in a very organized fashion. So you struggle with the fact that a lot of the data isn't so hot, okay? But let's expand it, and let's look at what we talked about the top 3. Now I just thought I'd deal with the next 4, and the next 4 on the list include mycophenolate mofetil. They include cyclosporin, tacrolimus, and a drug called cyclophosphamide, which is a very potent anti-inflammatory or immune suppressive or chemotherapeutic drug. And I didn't think I'd go through all of the ways. It's it'll put you to sleep after lunch. Maybe you're half asleep already. But there's different ways that we give these medications, and really for the most part they are oral medications. They can be given intravenously like cyclophosphamide, but most of the time they're oral medications. And again, the level of evidence that we have is not very promising. But these are medications that we use, and I'll come back to different indications later on. But that kind of completes what I would say is the conventional list of medications that we have to treat. So again, going back to the text, how do we choose the right drug? How does your doctor decide how to treat you? Sometimes they're simple decisions, and sometimes they're very complex decisions. So the way I look at it sometimes is to break it down, and as I said earlier this morning in the introduction, if we were just treating myositis, it maybe wouldn't be so complicated, but there are many different targets of myositis in the body. When we talk about inclusion body myositis, most of those patients have a much more asymmetric degree of muscle weakness, and they have predominantly attack on their muscle that leads to the weakness and atrophy. But when we talk about polymyositis, dermatomyositis, and those overlap disorders, we're talking about different targets. And certainly we know about muscle, certainly we know about skin, and certainly know about the GI tract and difficulty swallowing, which brings up the next drug that we need to consider that really isn't an immune suppressive agent. So does anybody know what drug I'd talk about that isn't immune suppressive that might treat some of these? I heard it. IVIG. Okay, somebody said it. And that's the next one on here. And I bring that up because when I go back to this, in addition to treating muscle, in addition to treating a muscle, it also treats skin problems, and it also treats difficulty swallowing. And that's IVIG. Now, I don't know if I put anything, I did put it up there because it's a little, so let's talk about IVIG for a minute. It's a very expensive drug. Anybody know how much that costs? Yeah, somebody's hit it pretty close, $18,000. When you're talking about a drug that's $20,000 a hit on a monthly basis, ouch. Okay, ouch from the standpoint of us justifying the use of that agent, and ouch from the standpoint of insurance agents or insurance companies or third-party payers, or if you have to pick up some of the cost of it yourself, which is an issue. So I put it up there. It's very important. We use it, and it came up again with IBM this morning. And there's different ways, but the point is that once I make a decision to use that drug, I just don't do it in perpetuity. All right, I try to vary my administration of it. So if I get a good response with it over time, I may go from 2 consecutive days every month to 1 day every month. And then I may go from 1 day every month to 1 day every 2 months or every 3 months. And I've got patients on different regimens. So I take a dynamic approach to the use of that medication, and I try to vary the dose over time. And usually that works okay. All right? And there actually was one very nice study done, and it was done in 1993, over 20 years ago, where they actually treated it in a placebo group, treated it in a regular group, crossed the patients over as what we sometimes do, and demonstrated some very nice effect on the muscle and the skin of patients with dermatomyositis. So it's a drug that we use, but it's not really that immune suppressive. We call it immunomodulatory. It modulates the immune system because it's a nice drug. Let's say you're in the hospital and you've got an infection, and but yet you've got active disease. It's a nice drug to be able to use because it doesn't really suppress the immune system greatly to worsen the infection, but yet it modulates the autoimmune attack on your body because it's immunomodulatory. That means it's immunoeffective, okay? So the list isn't just muscle, skin, and GI tract, all right? Sometimes it's joint problems, okay? Sometimes arthritis. In the Joe 1 patient, for example, we're not talking about autoantibodies here. I've talked about autoantibodies many times with patients in this meeting, but sometimes the Joe 1 patient has a disease that actually looks more like rheumatoid arthritis than it does myositis, and you may get treated like you have rheumatoid arthritis. And when that happens, you end up getting a whole different type of set of drugs that's actually used maybe to treat rheumatoid arthritis. And then, of course, as you did hear me talk about this morning, we've got lung. All right, that's killed many of my patients. All right, so it's a feature that is really close to my heart in terms of the need over the years and how we struggle with it. And these patients, as you well know, present with shortness of breath. They have inflammation in their lung tissue. And when they get that inflammation in their lung tissue, it then goes on to scar formation. And then when it goes on to scar formation, it's, you can't make scar go away. You can't make fibrosis go away, okay? So we have to try to prevent the formation of the fibrosis in an effort to control the inflammation. And that's the challenge behind interstitial lung disease, is to really take care of this broad spectrum of manifestations. So because it's so important, I thought I'd just kind of put a slide on its own in terms of interstitial lung disease. So obviously, as I said earlier, and as you might expect but might not like, prednisone is still the initial treatment because it gains more rapid control of the disease process, okay? And then there are many other medications over the years that many of us have used to allow us to control that attack on the lung, and that includes cyclophosphamide, nasothyronine. These are all medications I talked about before. That's why I waited here. CellCypt is actually being increasingly used to control the interstitial lung disease over time. We have published at Pitt on the use of tacrolimus, which is remember, that's the anti-transplant drug. Okay, we've published on that, particularly in Jo1 positive patients, and we felt that it's been effective in that group of patients. And then you even get to use, and this name was thrown out earlier by someone in the audience here, and now I'm going to talk about biologic agents called, biologic agent called rituximab. Okay, so that's the last group before I start entertaining questions from you guys, and that's the last group here. It's a whole group of what are called biologic agents, and 10 years ago we didn't have that on the list. Okay, so this is all new, and it's new because these medications have been used in rheumatoid arthritis and other autoimmune diseases, but there's a whole list of biologic agents, and I kind of listed some of them here. This isn't all of them by any stretch, okay, but the common ones include some of the ones in the first three that you know about. All three of these actually are now approved for use in rheumatoid arthritis, and they have been for many years. Enbrel, over almost 16, 17 years ago, was approved for the use in rheumatoid arthritis, was the first biologic, okay? Rituximab, I told you about rituximab being stolen from the oncologists. Well, that's a medication that's used to treat lymphoma, all right? Cancer. It's used to treat lymphoma, B-cell lymphoma, and now it's actually FDA approved for the use in rheumatoid arthritis. And we did the largest study ever done on this drug, a multi-center international trial that included people like Yuri Vinkovsky from the Czech Republic. He enrolled patients in this trial, and we looked at rituximab in the largest group ever done, ever studied. Okay, so these are ones that actually are approved for RA. This one, we're doing a trial on this now, centered at the University of Pittsburgh, looking at tocilizumab, an anti-cytokine. That means it's one of those inflammatory biomarkers that were mentioned this morning. It's an antibody against a biomarker, against a cytokine, and that cytokine is called IL-6. And then there's other ones that I kind of listed up there because this is also approved. These two are also approved for rheumatoid arthritis, okay? So we've got another whole group of drugs that's available to us now that we didn't have before. And we have a little bit better chance of using them because they've been used in other autoimmune illnesses as well as other diseases like malignancy. And then some of these are a little bit more experimental. I just thought I'd list on there cipalimumab. That's actually an anti-interferon. And what is interferon? That's some of the work that's been done on the panel of experts. It's an inflammatory marker that seems to be elevated more in dermatomyositis than polymyositis. And now there's an antibody, an antidote almost to that particular inflammatory marker, and that is this new drug that really isn't released for public use yet beyond clinical trials. So these are all biologics, and again, not much evidence, obviously, because it's very difficult to get studies like this going in terms of enrollment of patients. I think that's it, right? So I thought it sometimes is helpful to go through that. So what do you got? What questions you got? I'll
Go
you
left,
know,
right.
I'm here for a,
Back.
you know, we'll kind of, good, these guys are going to pass around the mic, and I'll just call on people right here.
Quick question for you. Have you ever had a patient that had cell sep toxicity? And if so, if it's working on the polymyositis, is it necessary to come off the cell sep and go on something else, or do you just wait and see what happens?
Well, can I ask you a question back?
Yes.
Okay. What was the type of cell sep toxicity are you talking
They
about?
didn't tell me. My
Oh.
gastroenterologist just said I have cell sep toxicity, and then my neurologist called and said we need to switch my medication.
Okay, so let me, I'll expand that on from my perspective, okay? So the question absolutely is, yes, we've seen cell sep toxicity, and it probably included one of the things that you can go back and look at on that slide set that I put up there. It might include a drop in a blood count, like a low white blood cell count, because it'll suppress the bone marrow's ability to make those blood cells. It could have been, if it was a gastroenterologist, one of the common side effects that we see are that people can't tolerate it from a GI standpoint. What we will sometimes do is cut the dose back. So we cut the dose back and we go up slower on the dosing. You noticed up there on that slide that we can give as much as 3,000 milligrams. I might start in some patients at 250 milligrams twice a day at a very low dose and escalate that dose very slowly over time. So once to answer your question, yes, every one of us up here, I'm sure, that's used cell sep has had cell sep toxicity, and then we have to cut back on it. And what we do is we oftentimes employ two different approaches: drop the dose, go low, go slow. Okay, go lower, go slower on the increase, or switching to a different medication. We're fortunate now. When I started in rheumatology in the 80s, actually we had gold shots for rheumatoid arthritis, gold, these intramuscular gold shots. And I remember, you know, the guys that trained me, I'm saying, are you kidding me? I got into this specialty and we're given this crap, you know, we're given this stuff. And then we got methotrexate in the 80s. And from there, look at that's a short list of what I put up there. So we got, bottom line, we got options. Yes?
I have a question concerning the debate of Imuran versus methotrexate, and I realize this depends if you're a rheumatologist, neurologist, and as far as my mom has a PM, and out of the toxicity kind of the Imuran, she's losing a lot of hair. And I was just wondering, is it just worth to just rather cut down a bit of the drug but risk potentially a relapse, or would you rather swap to methotrexate at another dose and you have less hair loss kind of toxicity out of that drug?
Right. Now you're a doctor, right?
Yes.
Yes, I remember. I saw you stand up this morning. So, yeah. So that's not. So you're smart. That's good. Smarter than me, I'm sure. But that's a great question because, and it brings up the art, as well as the science. Okay. So you asked a question, and I put it up there. That it's interesting. She had more hair loss on Imuran. I've seen more hair loss with methotrexate. just so you know, okay? But that's why I thought maybe you said the wrong immune suppressive. So, but your question was, okay, what do you do at that point? Do you cut the dose back? Well, let me tell you what the options are, okay? For Imuran, if it's hair loss related to Imuran, my guess is that it's probably just going to be progressive and an issue, okay? But the point is that we got options, okay? And if it bothers her, I'd say get off of it. I mean, I don't have any problem. I mean, unless it was a truly life-threatening, issue and the drug was super effective. But I'd say, okay, let's switch to something else. And the good thing about maybe switching to methotrexate, although I've seen hair loss with methotrexate, is sometimes we can give higher doses of folic acid, a vitamin, in patients that are given the methotrexate. And if that doesn't work, we can go to CellCept, or we can go to other medications, or we can lower the dose. We might even get away with lowering the dose and using a combination of methotrexate and Imuran. But I want to answer your question not in a dogmatic way. I want to answer it in a way that, yes, we have options available. Yes, we can switch to them. But you know something? You may get the same side effect when you switch to a different one. Does that answer your question? Okay. Yes, ma'am.
Hi, I'm on 15 milligrams methotrexate,
Yep.
and I'm allergic to ibuprofen and aspirin, and I'm in severe pain. What would you suggest for pain?
Yeah, so can I ask you, are you talking about joint pain? Are you talking about muscle pain? What kind of pain are you talking about?
Muscle pain in my legs. Every day is severe pain.
Do you ache all
Walking.
over? Do you ache all over?
No, my legs.
Just in your legs?
My thighs. My
mostly
upper
the thighs?
Yeah.
Were you weak in those areas before?
I don't have a lot of, I have some weakness, not a lot of weakness. It's more pain than
Okay.
weakness.
Okay, I actually took out a couple slides because in any disease like this, you have other problems, right? You have what are called comorbid or coexisting conditions. So I'm sure this audience knows about other painful conditions that can occur in patients with rheumatic illnesses. And sometimes that's why I asked you where, because sometimes it might be, remember I put up arthritis earlier? In a patient with Joe1 positive arthritis, we may control the muscle very well, but they may continue to have a problem with inflammatory joint pain. And we have to really jump on the inflammatory joint pain, and we do it in a different way. Now, you said muscle. In patients that have these diseases, they may have diffuse muscle pain. What is a disorder that causes diffuse muscle pain? Fibromyalgia? It's not a disease, right? But it's a problem. It's an ache and pain syndrome, and it's very real. And you may say, oh, my doctor told me, or your doctor may even not believe it in patients that have diffuse aches and pains, but believe me, it's a problem. And it's not a disease where I can get a blood test like I can with myositis and order a CPK and see that it's elevated. It's a syndrome, okay? You sleep lousy, you ache all over, you're fatigued during the day, you wake up in the morning, and even though you slept, you don't feel like you slept. I mean, the point is that it causes a lot of aches and pains. And that's very challenging because a lot of people will say, okay, give that patient an analgesic, a pain medication. And actually, treating a patient with fibromyalgia with a narcotic or an opioid or anti-inflammatory agents isn't really approved. I mean, it actually is contraindicated in our rheumatology literature. So the point that you have to get to is what is causing the pain. And sometimes, it's hard to get to that point, and you're left with the pain in your leg. And that pain is, you're allergic to the non-steroidal anti-inflammatories. But by the way, did they help you, though? Did you try them and help you, or did you never even try them?
Did I try?
Like Motrin, you said you're allergic to, right?
My throat closes.
Oh, yeah, okay. So you've got an aspirin-type allergy
Yeah.
where you get basically an anaphylactic-type
Yeah.
response with wheezing or closing of the throat. So you got to go down a different road. Well, there are different roads to use, and it may be, in your instance, that an opioid, that a narcotic may be necessary. But I would tend to try other things. Even acetaminophen sometimes in appropriate doses can be effective. Even sometimes other non-pharmacologic approaches to muscle pain can be helpful. And what people don't realize is that when they have fibromyalgia, they say, oh, I ache all over. And I tell them, what do I tell them? I say, well, you know something, you know what sometimes the best approach is? Normalize your sleep pattern and get into an exercise program. So I do use the holistic approach. And it is, some of the most effective responses in patients with fibromyalgia are when they are on an exercise program or normalize their sleep pattern. But it might come to something like tramadol. It's a pain medication. It's a little bit of an addictive potential, but it doesn't have the addictive potential of the narcotics. Another medication with you might be a whole list of medications that are used by neurologists and us too, called Neurontin, gabapentin. Maybe you've tried it before. Maybe you've tried Cymbalta. They're medications that are actually used to treat neurologic issues. It was brought up this morning, the patient with restless leg syndrome or something. There are a lot of different medications that are non-narcotic, non-immune suppressive that can be used. So actually there's probably a good list of different medications. So just a list, simple thing, acetaminophen, tramadol, Neurontin or gabapentin. Some of the other lower dose antidepressants can help with chronic pain, like amitriptyline. So there's a list of medications that can be tried. You just kind of have to be patient. But don't forget the non-pharmacologic approach, even a low-level exercise program. Again, it's a go low, go slow concept, slowly accelerated exercise program. If you sleep crappy, sorry about the grammar or the syntax, but if you got to work on sleep hygiene, okay? Not the long-winded answer, more than, yes, ma'am.
I've talked to several folks about this, but I had taken 2 infusions of Rituxan in July of 2012. All the other stuff just didn't seem to work. It seemed to work very well. When we rechecked the CD1920, there was like 0%, so we killed them. And that has continued.
You get it on a regular basis, is what you're...
No, I do not.
Oh, you just
No.
got it 2 years ago in 2000. 2
yeah.
years ago, you said?
Was in
Or no,
2012, 3 years
3 years ago. Huh?
Yeah.
Wow.
But my CD1920 is still like 0. So knowing that, yeah, I know, I'm weird. Oh, I guess we're all weird. But knowing that, is there any benefit or is there any contraindication to me taking like Pneumovax or any other kinds of things, influenza, any kind of, I know the shingles vaccine is probably out, but...
Yeah, so here's the question. So I'll rephrase that in a way that making sure that, because I know you understand what you're asking me. So your question is, okay, I don't have B cells anymore, and I need B cells. So what rituximab does, it goes after one arm of the immune system called the B cell. All right, it's a B cell depleting drug, BCD, B cell depleter. All right, and what happened with this patient is that she got it 3 years ago, and her B cells are still low. I suspect they're still low. The CD19, that's a marker for B cells, which is a little bit unusual. Maybe it's because you had other drug treatments in the past that, but what do B cells do? Well, B cells make antibodies. Well, that's why they might be working in patients with autoimmune disease, because the B cells make cytokines, they make antibodies, and they also help T cells to do their job. So when we hit and wipe out the B cell, we're trying to wipe out something that's, leading to the autoimmune component. Well, when you get a vaccine, what do you have to do in order for the vaccine to be active? The vaccine has to be able to induce the induction of antibodies, right? Little things that float around in your blood that keep away the shingles or keep away the pneumococcal vaccine or, neutralize the flu bug or whatever it is. And when you have no B cells, then maybe you're not able to get a vaccination. And your question, so that's a very long-winded, but I just wanted to explain it. But your question is, okay, can I get vaccinated, right? And are you also asking what can be done in terms of treatment or mainly about vaccination? Yeah, infections and stuff. I don't know the answer to that. I'll tell you why, because it's tough because you may actually, even though you don't have those cells, they may be somewhere in the body, like in a little sanctuary somewhere in the bone marrow, where that if you got vaccinated, you may actually have a response to vaccination. So one consideration that I think would be safe because you've had it a while ago is to vaccinate and check the response to the vaccination. And I think you can do that. So I would suggest that you talk to your doctor, which may include him even speaking with an infectious disease specialist, and say, hey, let's, I had this 3 years ago. I had this medication that, they know what rituximab is. Can I get vaccinated? And I'm sure when you ask your doctor that, he's probably afraid to do it, right? A little bit leery to do it. But maybe he needs to ask an infectious disease specialist, because I can tell you that there are some studies going on, and those patients actually can respond to vaccination, even though their counts may be low. So don't discount that possibility. Thank you. Does that answer it?
Okay, so my question is, I was diagnosed with polymyositis in 2000. 2004, I developed interstitial lung disease with a vengeance. So I was on a respirator for like 3 years. So then we got it under control, and I'm kind of off of that. I feel like dancing. I've gotten that under control, and I only have to do my breathing treatments, maybe twice a day. Approximately a month ago, I tried some innovative things. I'm down to 5 milligrams of prednisone. I tried
nothing else. That's it.
That's it, because we tried some of the other combinations, but nothing else gave me results. So I've been on prednisone since 2000. So I tried MSM and
what's that name?
MSM. It's not
MSM. Yeah,
prescription.
I know.
Okay,
That's
and
a lot for joint pain, by the way.
Right.
Uh-huh.
And God, the one for curry, turmeric.
Uh-huh.
And it
My wife's
did-
poisoning me with that. Yes, I know.
it did really well. It got me down to my 5%. 5 milligrams.
Yeah.
However, I'm noticing something, and I'm not sure what it is. But I don't know what kind of test, because when I went to my doctor, I could get up out the chair, and I had the strength.
Yeah.
And the CPK was looking
Yeah.
regular. So I'm trying to find out what other kind of tests, said all that to say, what other kind of tests or what else can I have them look for to see if these things are having a negative reaction, or should I be going to that cyclophosphamide, which is
No way.
specifically for
No,
ILD?
no. Those are great
Okay.
questions. Can I rephrase that as well? So you're pretty stable. Do you feel like things are stable now? Is that what you're saying? Or do you feel like something's not quite right?
It's stable in that I definitely don't feel like I used to.
Yeah.
But I'm noticing it's just that underlying something, a twitch here and a ache there. It's something.
No, those are
Well, I
very.
know.
That's a terrific question. Let me tell you why. Because, you're trying to get a jump on things is one thing we're trying to do. Okay, you're trying to stay ahead of the game. Okay, my guess is that you're probably doing okay if your blood tests look okay. And I'm sure part of those tests include breathing studies that you get on a fairly regular basis, right? Pulmonary function test. They fluctuate, but they're not headed in a completely downward way. Okay, well, you need to know. Well, you need to discuss that with your doctor, because in your case, it might be that the lung is going to be the only thing that really flares again. It may not be. I mean, do you have the Jo-1 antibody, or don't you even know? That's okay. That's a. Okay, well, they may not tell you, but they don't. We don't tell you. We don't go through every single lab test, because sometimes it'll freak you out. But you should ask, because that is an antibody that goes along with muscle being a problem, the lung being a problem. But let me get back specifically to the question. The question is, what can you do? Well, here's what I would say is, most of the time, you're not going to present and have a major problem in one way and then later on go in a completely different direction. So if you're going to get into trouble again, it's probably going to be the muscle in the lung or something like that, okay? Did you have skin problems? Okay, so that's good. Because you said you had polymyositis, so you didn't have much skin problem. So I think that in your case, you have to watch. You have to know your body, okay? And you have to see if you're kind of repeating history of what was a problem with you before. In addition to you doing that, you have to make sure and talk to your doctor about saying, hey, we need to keep an eye on my pulmonary function tests. If you're not followed by a careful guy, or gal, you gotta say, well, what do my pulmonary tests, what do my lung function tests look like? So I would tell you just to get the metrics, get the things in order that are going to be a problem in terms of how we gauge your disease activity. Look at, are the muscle enzymes normal? How is my muscle strength doing? And how are my pulmonary function tests doing? And I have no problem with you trying some of those other alternative type medications. And we can go, I actually took that slide out. MSM, fish oil, turmeric, you can sprinkle it on things, right? Don't you? Is that what you do? You take the capsules? Yeah, that's a lot. I've got a fellow that I work with. He's from Korea, and and the Asian couple from and they really swear by that. And it's got some data that shows that it's got some effect. So those are okay. You got to be careful and make sure your doctor knows that. But I have no troubles with that. Just as a sidelight. But in addition to allowing that, keep the follow-up of the other things. You can't get CAT scans all the time. I mentioned that this morning. Remember the lady that asked about the tumor marker? You can't get CAT scans every 3 months, but if the pulmonary function test shows some type of decline, well, the next test is to do a CT scan to see if there's any evidence of activity. So you're doing the right thing, and I'd say that just because you have a twitch here, sometimes there's a level of anxiety, okay? You get a little worried about things. You had some significantly significant things that happened, okay? So you have to be kind of on the guard for that. So you're doing the right thing. Yes, sir.
Well, as you can probably tell by my appearance, I've been on high doses of steroids for
Yes.
quite some time.
Yes.
How do I know, like, the difference between, like, the dermatomyositis causing my muscle weakness or steroid-induced myopathy?
I don't know. No, I do know. That's the question here is, okay, I didn't mention that earlier, did I, as a side effect of steroids, but so you talk about a two-edged sword, the exact thing that the steroids are treating in this young man here with dermato is, what is one of the side effects of steroids? It causes a very similar pattern of muscle weakness. It's called steroid myopathy. And myopathy, obviously, that's an attack on muscle. And one way to be able to tell, and so he's struggling now. He's got steroids that treat the inflammation part of the muscle disease, but then you probably also now have this other, maybe it's different, maybe it's the same type of weakness where maybe your doctor says, well, you've got weakness in the arm muscles, you've got weakness in the leg muscles, you have difficulty getting up out of a chair on your own, and is it drug? Is it disease? Well, the question here is, or there's a kind of like an approach that you have to make, and sometimes that approach is actually to taper the steroids a little bit more aggressively. That's what I tend to do. Taper the steroids a little bit more aggressively and watch what happens with this muscle weakness. If this muscle weakness actually improves, then it may have been a component of steroid myopathy. If the muscle weakness worsens and the muscle enzymes go higher, then it may be an element of disease activity. So do you know at this time if the muscle enzymes are normal or are they still high?
Well, like, I'll have varying times. Like, I may have like a flare and the muscle enzymes will be 13,000, 20,000. And then I could be feeling absolutely horrible and my enzymes are like 80,000.
Yeah.
But like every time I try to taper, when I get to like 30 milligrams,
Yep.
then I'm in the hospital for a couple weeks.
Okay, so you've got refractory disease beyond steroid, and you're also taking other things besides steroids.
I take methotrexate, and usually when I'm in the hospital, then I take like IVIG.
IVIG, I got you. And how long have you had the disease?
3 years, since 2012.
You've never been off steroids?
No, I started it, due to a pharmaceutical error, or a pharmacy error, then I was on 120 milligrams for
Orally?
quite some time, yeah. And then, like, I've made it to 30. I'm on 20 right now, and that's the lowest I've ever been.
Okay, that was my next question. The lowest you've ever been is 20. So, you may have two things. You may have ongoing disease activity that requires aggressive therapy, obviously, but there also may be a component of steroid myopathy. So it still may be the same approach of trying to taper the prednisone, but if that prednisone taper then leads to a higher elevation of the CK, then it's probably just tough aggressive disease, which doesn't mean that it can't get better down the road, but it just may mean that it requires a more aggressive approach. And the approach sounds pretty aggressive, but it may also include more different types of non-steroid medication for you that might be the combination of methotrexate and Imuran. And I don't know how familiar your rheumatologist is with treating myositis. It may be. Where are you from? Oh, okay. I know people there. Rheumatology or neurology? Okay, both. All right. The Ohio State, you like Ohio State? You can leave. Yeah. Well, who's going to start at quarterback today? Which one of the three? Anyway, but there's good doctors there. And in fact, one of the doctors that's going to come on the board next year is from Ohio State, and he does research there. Dr. Jarjour, who is, Whale is, and he's more research-based, but those are good doctors there. And it's a tough disease, and I think the point, the shorter answer is that it's probably a combination, and it may require more aggressive non-steroid medications, and some of the other ones that I have on the list there. Yes.
Thank you again for being here this year. I have two quick comments, if I may, and then I have two related questions. One, some of you have met me already because I did the nutrition talk, and some of you know I'm a physician. So if I might just real quick, to the young lady here who said about the aspirin allergy, I'm an allergist and immunologist by training. So allergists can desensitize you to aspirin and ibuprofen. I do it all the time. So you have to do it very safely, but it is done. So you might, and we can talk later if you want to find out a little bit more about that. And then secondly, also to Teresa, hi. Your question, and actually this is sort of related to a question I have for you, Dr. Oddis, is the problem with vaccines, because I deal with this in my own practice, is sometimes you have to get proof of antibodies to know that if the patient's making antibodies or not. So if you've had a tetanus or diphtheria or a pneumococcus, did you ever have a pneumococcus at all? A pneumovax, sorry. You did have one. So they can get diphtheria, tetanus, and pneumococcal titers on you, or they could just do like Dr. Oddis said, just give you a pneumovax because that's dead and it won't cause any problems even if you have no B cells, and then they can see if you have a response to that. But sorry, I just want
So, no, but what would you tell her about live viruses, though?
No, not live viruses.
Not live viruses.
Because in
not-
fact,
Yeah.
in the old days, the sad thing is, and still sometimes with pediatric patients with immune deficiency, sometimes when we used to have the live polio vaccine, they would find out that's how they had an immune deficiency because they got polio from it. So a live vaccine you have to be very careful about. But that leads me to a question to you. So I am on IVIG, and every year or so the hospital says you have to get a flu vaccine because I don't really work in the hospital, but it's mandated. And I say, well, it's not going to work for me because I'm on IVIG. And from my immune background, that's my understanding. And I got my Pneumovax before I started on methotrexate and on IVIG. But do you still recommend your patients on IVIG to get vaccines? Because technically, I would think they wouldn't work.
Yeah, geez, actually...
Because they would bind the vaccine,
Yeah,
the antibodies would negate the
Is
vaccine.
that absolutely proven, though?
Well,
I don't think it is.
I've looked and looked in the literature, and so I'm asking you what your recommendations are.
No, and we do have patients that are on IVIG, and usually it's not the IVIG that limits. Everybody gets the influenza, the pneumovax in the year. It's the ones like the varicella, the other live viruses.
Right.
And when they're on a biologic, no live viruses.
But IVIG, like you said, it's
but
not...
IVIG, I actually have told my patients that they should be vaccinated.
I mean, it's not like it's harmful.
I don't think it's harmful, but you're just talking about the efficacy. The only really way to know then is to really check for titers, and I tell
But
you what.
you can't check for titers when you're on IVIG.
Well, that's true because you get all. Yeah, that happened recently, by the way. I checked for something, and this patient on IVIG ended up having varicella IgM just for you.
IgM, right.
Yeah, and I talked to the ID person, and actually you can have false positive results when you get IVIG in terms of viral type titers on things because it's a pooled. One of the donors for the IVIG probably had gamma globulin, an IgM or an IgG in their blood. So anyway, but that's a complicated thing. To get to your question, I actually do in patients that are on IVIG, but
I just figured it wouldn't work. So
but you may be right. I don't think there's data.
Okay, well, I haven't found it either. Okay, so my other question about IVIG is, do you ever see patients who it just stops working? The reason I'm asking is I've been on it for about 3.5 years because I'm now full-time and used to be part-time. I'm trying to be on farther away and a lower dose. So I'm still getting it 2 days in a row. I'm trying to lower my dose, but it's getting harder and harder to do it. So I'm every 6 weeks, but I'm getting 60 and 40 grams instead of 60 and 60, and now my skin disease is coming back.
Really?
So, and my psoriasis, which is weird because that has nothing to do with this, really, and the methotrexate had always taken care of that. So I'm just worried if I'm getting like tachyphylactic to it, meaning it's not working anymore, or...
Yeah, that's a good question. So the question here from a doctor who knows a lot about the disease as well as knowing about the underlying diseases is she mentioned the term tachyphylaxis. That means losing an effect to a drug over time. And the question is the IVIG losing its effectiveness over time? I have seen that, but the remarkable thing about IVIG that I've seen is that it keeps working. So I'm guessing that perhaps the lack of efficacy might be the fact that you indeed have dropped the dose and increased the interval. Right. And I wouldn't be so negative about it not working.
I hope not,
because it's been effective for you. Skin mainly?
Only skin now. My muscles are fine.
That's great. And you don't want to take other medications, or they've not been as effective? Because I found, just as an aside, before you even respond, is that sometimes the most effective treatment that I've had for bad skin has been the IVIG. refractory skin, only problem. Go ahead. What
Well,
were
I
you
was
gonna-
just going to say real quickly, because I know other people have, I had a horrible, I was one of those 1 in 3 that had a horrible reaction to Plaquenil.
Oh, yeah. Yep. What was that horrible reaction? Like you had a terrible sunburn?
Oh, head to toe red,
Yeah,
itching
red.
out of my mind. They
Yep.
increased my prednisone. It was like classic 2 weeks into it.
Yep.
I had GI symptoms with Cellcept. I was on 25 a week of methotrexate and it didn't
Yep.
work.
Yeah. So
And
you really
I wanted to get out, and I was off prednisone. I didn't want to go back on it.
got it.
All right, before we give this one over here, listening to two doctors talk was like being in Spain and not understanding Spanish. I got to tell you, when you guys
See.
were at it.
Okay, I'm on methotrexate, and one of the problems I have, which the doctors can't tell me the reason, but I have the pain and the ulcers in the mouth, which I feel is a side effect from the methotrexate, and which they only started me on 2 milligrams of the folic acid. What is the recommended dosage that will help?
Yeah, it's actually 1 milligram daily right off the bat. Okay, now they bumped it to 2. You know, there's actually
help. I don't feel any results.
no change. Well, there's actually a third thing that you can do with folic acid, and that is take what's called leucovorin or folinic, F-O-L-I-N-I-C, acid or leucovorin, and you can actually take a 5 milligram tablet 12 to 24 hours after you take the methotrexate weekly to see if that helps it. So ask them about leucovorin, Leucovorin, or folinic acid, which is the same thing. That is one step beyond the folic acid. And it may be that that doesn't work either and you got to switch to a different one. But you're right that the mouth ulcers are a common side effect. Yes. Oh, yes, right.
My question has to do with going off of medications.
Uh-huh.
For example, you know, I had some side effects of prednisone, and I'd been asking to go off of prednisone, but finally we are moving off of prednisone. But my concern is that...
Is the microphone not working?
My concern is that sometimes we are left on these medications too long, and possibly we're doing well. So how do you know to go off of them?
I don't.
Oh, you don't?
No,
Do
I'm
does
being
the patient
facetious
just
again,
ask?
but I'm going to tell you that the question here is, okay, you're doing well. You're on prednisone. I mean, maybe you're on 5 milligrams of prednisone and you say, well, can I get off prednisone? Or I have many patients who've saying, well, I've actually had the opposite. I've want to take patients off it, and I have a couple where they're afraid. They're afraid because it was so bad. Like this woman just mentioned earlier here. I have a patient who had really bad lung problems, and I felt like we really saved her with tacrolimus. And she felt she was saved, and I said, you know, but I worry about it over time. I worry about taking those medications, you know, long term. And I wanted to stop it, and she didn't really want to, but she complied and stopped it, and wouldn't you know that she had a flare of lung disease, and I never would have expected it. So I worry about that now. I mean, not just that one. I've had others where they've been stable for maybe a couple years, maybe longer. And I think, oh, I know I can get away with it. And, you know, I mean, that's why, I mean, I learn all the time. I mean, I think I'm going to get away with it, and I don't, and I get a little bit of a flare. So it's a tough problem. But I generally, in response to your question, are you basically asking about the 5 milligrams of prednisone that you're still on? Or are you asking about...
I'm on hydroxychloroquine.
You're on hydroxychloroquine, Plaquenil.
Going off of prednisone, and there were 2 other medications that we got rid of because I had problems with them. Oh, I'm sorry. I had, right now I'm on hydroxychloroquine, which is Plaquenil, and I'm going off of prednisone.
Yep.
At one time, I was on methotrexate and flutamide, but I had problems with those 2, so they opted to not do anything.
Okay.
And I did fine.
Okay.
So the question I have is I would like to go down, and we have in the prednisone, but my rheumatologist was saying that it's best to keep the hydroxychloroquine as a base to calm the disease.
I agree.
How do you...
I agree with that. The comment she made is that her rheumatologist is telling her, look, things are pretty stable. Why don't we keep the Plaquenil, the hydroxychloroquine, on board as a base to kind of keep things quiet? And that is the thinking in lupus, where patients with lupus really don't come off Plaquenil unless there's a bad side effect. And you may be worried about the eye side effects on hydroxychloroquine or Plaquenil. There, it's quite rare, and it can be monitored. But I would kind of tend to agree with the rheumatologist because Plaquenil is a little different from some of the other ones. It doesn't suppress the bone marrow. It doesn't cause infection. It really only tends to keep the disease quiet. It's a little gun, not a big gun, but it keeps the disease quiet, and it has a lower number of side effects, and you just have to monitor for the eye. So that's a good medication if it's being tolerated to keep on board. And I would tend to taper the other non-Plaquenil medications.
Thank you very much.
Thank you.
Yes.
Hi. Actually, my question is about going back on medications. I came off all medications in 2012 and was feeling fine. I was doing great, but my CK levels have been hovering between 1,500 and 4,000 for the last couple of years. So recently, my rheumatologist in Calgary, Canada, had recommended I just go back onto some methotrexate about 5 months ago, just because he wasn't comfortable having my CK levels high, even though I felt good.
Did you feel totally normal?
Yes, I did. I was just starting to get maybe the fear in my head of weakness coming back because the levels were going up. So I started on the methotrexate 5 months ago, and then the weakness came back immediately. Now, I don't know if methotrexate can cause weakness like you were talking about with the prednisone, or if it went in my head, or, how do you know when, if you're feeling good, how do you know if I should go out? And would I do any damage to my muscles, continuing if I'm feeling good at a CK level of 4,000 without medication?
Yeah, those are questions that are excellent. So let me just restate it again. You've got an underlying disease, polymyositis, or pardon me? And it's besides muscle. Was there any other? Was it biopsy proven? Yes. Were you weak in the beginning when you had it? So it's a pretty definite. So we always have to remember with polymyositis, it doesn't have the classic rash. You got to make sure that there's no mimic, no masquerader going on. And that's why you have to make sure that the biopsy reveals evidence of polymyositis, because a lot of people are being treated and there's no absolute diagnosis, but I'm assuming that let's make the assumption that the diagnosis, that it is correct. So then you're left with the CK being elevated, and I have a kind of a thought on that. If the CK continues to be elevated and it stays in the range where you're talking about, maybe it's 1,000, a couple thousand, but it stays there, and you have absolutely no symptoms, zero symptoms. Sometimes I am now in the habit of watching that and monitoring that, and maybe I'm not going to see you yearly. I'm going to see you more frequently, maybe even monthly for a while, maybe every 3 months. And I'm going to monitor your muscle strength. I'm going to talk to you. And if that's the only other thing that's going on, I'm going to make doggone sure that I have the right diagnosis. And one of those things may include another biopsy, just to make sure that we're not dealing with something else that causes elevation of the CK that's not autoimmune. Okay, so you got to be careful of that. Because what happened now is that you were started back on immune suppressive therapy, and you're worse. And maybe it's because because sometimes the CK will go up, and there'll be no problem, but as the CK stays up, the weakness starts to recur again. So that might have been the case with you, but it may not have been the case. You asked another question, that is, does methotrexate cause muscle weakness? No, I haven't seen that. So it's not like steroids where you get a steroid myopathy. So I know I said a lot of things there, but I think at some point it may take, taking a step back, going off of the methotrexate, and even considering redoing a biopsy or redoing an MRI, or doing an MRI to see if there's any evidence of inflammation in muscle tissue. If there is evidence of inflammation on the MRI, then biopsy in that area where the inflammation is showing. So it may take a rethink on the part of your doctor. Is that a rheumatologist or a neurologist? In Canada? Yeah, in Calgary. Yeah, I'm not sure I know who that would be, but that's okay. It may take that doctor, that rheumatologist, kind of rethinking, and discuss it with them. Bring up the things that I brought up. Okay. Yes. Is there a mic? Oh, yes.
The question I was going to ask was, if you're stable, what would be a normal interval for follow-up testing? Monthly, every 3 months?
You mean if you're stable on no disease or on no therapy
I'm 17 years in. Mm-hmm. I was getting immunoglobulin weekly 18 years in actually. I'm now back to immunoglobulin biweekly. I still take prednisone daily, 6 milligrams, and I'm taking 20 milligrams of methotrexate. And I'm just wondering, how frequently should we be checking like the CK and the aldolase?
And has the CK been a pretty good marker for you in the past?
Over the last 15 years, yes, and I've had some recent bumps in the road. But I'm just wondering, is it something monthly, bi-monthly?
Yeah, I think in your case, if you've been pretty stable, you can even do something like that every couple of months. You don't want to do it every 6 months. You don't have to do it monthly. Probably your doctor will learn by following it every couple of months. If he gets nervous or something is awry or starts to elevate, then you might do it monthly. And if you're quite stable over time, and you've really been very stable over time, you can even stretch out the CK and the visits to every 3 to 6 months with your doctor, because you know your disease and you know your body, and you can always say, look, I think things are going on. Maybe we want to check a muscle enzyme, especially if it's been a pretty good marker for you in the past. Okay?
Thank you.
Thank you for coming out. Prednisone was my new friend who never left my side. And when I was first diagnosed in 1997, I was 20,000, my CK level. In 6 months, it hit 1,100, and I've been stable ever since. But I was wondering, I'm taking methotrexate now.
Yep.
And 2.5 milligrams on Friday, 3 of them. And now my liver enzymes are high. But you know, I was telling my doctor I also do water aerobics and exercise. So does that correlation with the inflammation with the liver, or do I need a new liver maybe in 2 more months?
Well, so the enzymes have been okay, the muscle enzymes, it's just the liver tests that are elevated. Yes. Is that correct? Yes. And there's no other new drugs, right? You're still on the same dose of methotrexate as before, no new drugs. And how high were the enzymes? Do you know? Or?
I think it was 80.
Okay, so they're a couple times normal. Well, in an instance like that, we're probably going to monitor you on a monthly basis and see which direction they go. And there's a couple different options. If they continue to be elevated and they don't go down, then you might want to drop the methotrexate dose and see what happens. Okay? You want to make sure you're taking no other drugs, and a drug includes alcohol that would worsen that. So no other medications or alcohol that could worsen it. And it may be that you have to come off of it if the liver enzymes stay elevated. So it probably is related to the methotrexate, but you can't always make that assumption. Does that answer your question, or what?
Yes, it does, because I was on it for 5 years and I loved it. I mean, I really was feeling great and feeling good. So when she told me, that was kind of like...
But sometimes you'll get that bump and it'll go away. That's why you don't want to overreact, while at the same time you have to continue to monitor.
Thank you.
Yep. Yes.
I'm one of the newbies here. I just got a skin biopsy back yesterday, so I guess I'm in the DM spectrum of things. And so far I've just used topical medications. Is there a reason to go on Plaquenil? Should you quiet it if...
So it's really only a skin rash, no muscle, no lung, no joints. Really, and how bad is the skin rash?
It's confined to my hands right now, but I also get the scarf and the V.
On the front and the back. Well, I think in this instance, I'd probably try Plaquenil. I don't think it's the best drug, but I think it might calm things down. That's probably what a dermatologist and a rheumatologist local would recommend in this instance. And the good thing about it is you can give it a while. Try remember, Plaquenil is a slow-acting drug, and if we give it to you today, we're probably not going to make a decision as to whether it works or not for a period of 3 to 6 months. Okay, so you have to give it time. But if it's mild and in those areas and you're only on topical medication, Plaquenil would probably be my first choice. And then I would go through the same sequence that we went through, because I think that some patients, even though it's only the skin, need to be treated a little bit more aggressively. So I think that, to answer your question, Plaquenil is a good choice.
And what's the dose?
Usually start off at 200 milligrams daily, and you don't go much higher than 400 milligrams a day, and oftentimes it's dependent on your weight. So it might range from 200 to 400 a day.
Okay, and is there anything with when you take it, time of day?
No,
or?
not really. Not really. That's a medication that can be taken, daily. A lot of people divide it up twice a day because it might be a little easier on the stomach, but sometimes I've told my patients to take it all at once in the morning.
Okay, thanks.
Yes.
Hi, it's me again with the RLS symptoms, but I also was diagnosed with JO1 in 2009.
You, at the Cleveland Clinic, they manage you there, I remember, right?
Yes, and was on the ventilator. I have the ILD. I tried the methotrexate. I've tried Cellcept. I'm on the Prograf for the ILD. I've tried the Imuron. I've tried everything that you've suggested. You've listed. But was on Imbral injections for 7 years because
for what?
Imbral injections.
Oh, okay.
For 7 years
for what?
For RA.
Oh, for RA.
Prior to 2009.
Well, that's because you probably had a lot of rheumatoid arthritis-like symptoms because of the JO1.
Correct. But they didn't know that then, and so then when that suppressed my immune system more, and that's what put me on the ventilator. Until they did the lung wedge and found out I had the JO1.
Right.
My question is I'm currently on the IVIG. I've only had 5.
5 monthly treatments.
Correct. I've only been on it 5 months.
And were they using that to treat the lung?
And since I can't do the Cellcept anymore and the Prograf wasn't working for my myositis, then they...
Okay.
And I'm only on 4 milligrams of Medrol. But that's another question. I refuse to take any more steroids. And my husband and I have made that decision because it caused so much GI distress. Anytime I eat, I bloat, and I still have stomach problems to this day, and from the steroids. But I still have leg cramps and the RLS, and now I'm developing tremors. Your one slide mentioned the IVIG 3 to 6 months, and Dr. Langford in Cleveland, my doctor, she stated
Carol,
that.
very well.
Thank you. I do too. She stated that she'll only give it up to 6 months. But then what's next? That's my big question. Should I suggest the rituximab, or what's next?
You don't have to suggest that to her.
She's
she
very
knows.
Good.
Yeah.
I'm very fortunate. She saved my life.
Yeah, she's terrific. So I know. I mean, yeah, I think that's probably something she would consider doing. Yeah.
I see Dr. Mehta as my pulmonologist there, and he's willing to do a lung transplant on me if I have to need.
Right, but they're going to hold off on that as much as possible. But there's probably. I mean, you've had a lot of the medication. I don't know. Your case sounds familiar. I don't know if she even emailed me about you in the past, but I can.
I'm her miracle patient. She says.
Yeah. So I mean, I see patients frequently from the Cleveland Clinic group, and the important thing here is that is the lung disease stable right now?
It is.
Okay, and you are on the maintenance of the IVIG. You're on. She said Medrol. That's prednisone. Only you're on 4 milligrams. That's the equivalent of 5 milligrams of prednisone a day. So that's it's a low dose. That's fine. And you're also on. I don't know what other medication you said.
Prograf.
You are on Prograf.
I take 6 tabs a day.
Yeah. So Prograf is that's our data that we actually published almost 10 years ago using Prograf for interstitial lung disease in JO1 positive patients. So that's a effective regimen. If there was a flare and Cellcept wasn't tolerated, right?
Correct.
Yeah, because I've added Cellcept to this, but what I would consider doing is the rituximab if the lung disease gets to be a problem.
So how long do you think she'll keep me on the IVIG? Will there be an interval?
Oh, I think it's going to depend on if it continues to control. I would think that she'd have no problem keeping that on board for indefinitely if it keeps your disease under control.
Okay, because my CK went up to 500 and then it immediately dropped to 69. So I'm back down to 69.
Right.
But the GI distress, will that ever get better?
Yeah, I don't know. I mean, that's could be from different causes. Remember, you can get actually overlap of esophagus problems with any of our diseases, and there may be dysmotility, that means abnormal function of the
Correct.
esophagus. There might be reflux, and that may be a persistent problem that you struggle with. And I'm not so sure it's related to the previous prednisone use. It may be just related to the underlying disease too.
Okay, because see, I'm an oncology nurse, and so a lot of these are the cancer drugs.
Oh, you know.
And
yeah.
everything, and
Yeah.
I just didn't know if that was causing some of my distress.
I don't think IVIG is doing it. I doubt that 4 milligrams of Medrol is doing it. You know, tacrolimus, some people have GI problems on the Prograf or tacrolimus. You know, that's the same medication.
Right.
Prograf, tacrolimus are the same anti-transplant drug. You know, some people have GI problems. I mean, so it could be, again, multifactorial, multiple causes. Tough for me to know exactly what to do, but that's a pretty good regimen, and there's other things to try after that.
Do you have a prognosis? Because to be honest with you, sir, I really am a miracle that I survived the first time.
And you're not on oxygen, or you are on oxygen? No, I can't. I don't see.
I was told 2 years one time by a physician. I was told 5 years by another, and I've surpassed both of them so far. Yeah.
Well, so I really think that that's great, you know, but I think that the prognosis might actually be better now the farther you go along, and particularly if you don't. I mean, you talked about transplant, but if you're not on oxygen, there's nobody that's going to transplant you.
No, not
I mean, you're not near that, so that's a good thing.
I was before.
You were before, I know, but that's an indication that you got better. So I mean, I think you could actually live a normal duration lifespan. I've had patients that have been through, because I've seen a lot of interstitial lung disease, and you know, we thought that, man, it's going to be a year, it's going to be 2, and it's 10, 15 years down the road.
It's hard for me to put my mind around it.
I understand that.
Accept it now.
Yep.
Because I've been the nurse and the
Oh,
patient
sure.
now, and
Oh,
so
man.
it's really hard for me to
Yeah.
grab my mind.
That's right. Well, you might. Okay.
Actually, I have a comment and a question for you, whose mom who has DM, the doctor. A lot of us take biotin 5,000, and the dermatologist in the DM thing had mentioned that as well, that it really does help with hair growth, and also, as
Oh
the
yeah, the
doctor was
biotin.
saying,
Yeah, that does.
yeah,
Has it helped you?
5,000 milligrams a day or whatever.
Good.
Biotin's really good, and also increasing the folic acid. And the question I have actually is kind of goes along with that in terms of the rituximab. I had tapered down to 4.5, and I ended up with a flare, which threw me into the hospital. And at that time, I was doing, I still am, IVIG, prednisone, methotrexate, and Plaquenil. And I'm at Duke, and she had consulted with someone at Johns Hopkins who said, add the rituximab to the mix. But it occurred to me all of a sudden, I don't know what the side effects are. So quick question.
Yeah. So right now, but I'm just curious. So you're on IVIG.
Yes.
And you're on methotrexate.
Yes.
And you're on Plaquenil.
Plaquenil and IVIG, prednisone. Of course, they threw me back into the prednisone, so I'm at 50 now. I was doing
you're
great
puffy.
as I tapered.
So what
down,
did they increase the prednisone for? Was it increased for lung?
The
prednisone was increased for lung problems?
For the inflammation once I ended up back in the hospital. And they're not sure if it was the tapering down. I was doing great for 5 to 6 months, almost 100%.
But now they're talking about adding rituximab to try to get the prednisone lower. And your question is?
They already did do it.
Oh, you already got rituximab.
I've done the, they say one, and then 6 weeks later the other. I haven't done the 6 months one, and then that'll be it.
Usually it's one dose and then 2 weeks later. The second
maybe
dose.
It was 2 weeks.
Okay, yeah. So you already had the 2 doses.
Yes.
And so the question that, Andy Mammon and I were talking about this. Andy is from Hopkins, and we've used a lot of.
And actually, I do have necrotizing myopathy.
Oh, you have necrotizing. Okay. So yeah, that's from a statin. No, non-statin. So this is being aggressive, and usually those patients, patients like you respond to IVIG pretty well. So the question is, what about the dosing of the rituximab? Well, you got the first dose, and the question is, do Do we wait 6 months and just give a standard dose? And their practice is more giving the dose now, and then every 6 months giving a 1 gram, 1 dose of rituximab. And I've done that in patients that have been smoldering activity, but in patients that have absolutely no disease activity, I've tended to try to space it out longer. So it's just a difference in style.
Actually, I guess the question is side effects. I just realized are there any side effects?
Oh, with the rituximab? Well, if you didn't have an infusion reaction, you may notice like you didn't even take anything.
Right.
But there are other side effects, and the side effects of rituximab long term are that it kind of decreases your gamma globulin, and we've seen that over time. And a physician earlier that mentioned on following things like that over time, it can actually drop your gamma globulins, your IgG, IgM more than IgG level, so it may impair your ability to fight infection. But for the most part, there's not a huge increase in infection on rituximab. There are some very rare side effects of rituximab. One is called PML, progressive multifocal leukoencephalopathy, long name. It's a deadly degenerative disease process, but it really only occurs in patients that have had other multiple chemotherapy agents. So for the most part, it's pretty well tolerated. If you don't have the acute infusion reaction, you don't have to monitor. You don't monitor things ongoing. In fact, I don't even check the B cell count in many patients. I just kind of follow patients, and they're usually on other immune suppressive medications, but there's really no persistent monitoring necessary. And the side effects, if you didn't have big problems already, you're probably not even going to notice it.
And same goes for Plaquenil. If you didn't have any side effects right away.
Oh, yeah, Plaquenil's pretty well tolerated. You got to get your eye, as I told you, got to get your eyes checked every 6 to 12 months on a regular basis. That's it. Yep. You won't even, maybe GI side effects from Plaquenil, but not a lot of, but no blood monitoring is even necessary on Plaquenil, like you have to do with methotrexate, Imuran, Cellcept, the others. Yes. I'll repeat the question. So, and was the question if somebody needs prednisone for polymyositis,
if you're diagnosed with polymyositis, how long would you keep somebody on prednisone, or are you going to be able, or are we going to take it the rest of our lives?
Oh, no. I mean, I try. If the disease is stable and goes into remission, I taper and discontinue. I mean, I don't have most of my patients, but I've got many patients that have had dermatomyositis, polymyositis, usually not outrageously severe, but significant problems with it, and they've come off steroids. Yeah. Is that the question?
Well, I've been on steroids for 11 years, and I can go off for about 9 months and then have a flare-up, and I've been told I'm probably going to have to take it like the rest of your life.
And the dose is low?
Right now it's at 5, and in a flare-up, and my doctor left town and said, just up your prednisone.
Well, I still think that it's not a bad idea to try to keep tapering prednisone in the setting, even if you've been on it for 10, 11, 15 years. Try to taper it, get to the lowest dose possible, and if you can't get off of it completely, it's not a disaster to be on 2.5 to 5 milligrams a day. I mean, it's not like 0, but it's fairly well tolerated. We just have to watch for, watch the bones, watch for cataracts and other things like that. So I don't think that that's a disaster to be on a low dose chronically like that. But again, I recognize and respect that drug. Does that answer it? Yes. Okay. Yes.
I have a unique model. I was diagnosed 20 years ago with primary immunodeficiency, common variable immunodeficiency.
Yep.
In the last 5 years, developed multiple autoimmune issues, the worst being dermatomyositis. There's kind of a dilemma with my physician team on figuring out, because my CPK and Adelase are always normal, because I don't make antibodies. So it's difficult to do the standardized testing on me. Curious if you've dealt with any PI patients with DM yet.
Yeah, I mean, I've taken care of a handful over the years, and those patients continue. So you get IVIG on a monthly basis?
Yeah, I do sub-Q.
Sub-Q.
1 gram per kilogram now.
Okay, a gram per kilogram monthly?
Yes.
And are you on any other medication for the DM?
Steroids off of about 90 days ago.
Oh.
And Rituxan every 6 months.
Oh, that's interesting. What do you, can I ask you about being an allergist and immunologist, wondering about this? But we see CVID, we see primary immunodeficiency, because in those patients like you, they have this thread of autoimmunity that tends to occur in patients like you. And it makes treatment a little bit more challenging because you have an immune deficiency. But really, if you keep up with the gamma globulin, the immunoglobulin, oftentimes we will have to co-administer other immune suppressive medications, and we just have to watch very carefully for infection. That's kind of like my overall approach to what you said.
Right.
But did you have a specific question on a medication, or?
Well, they're not quite sure the next step because I keep flaring. And they've done some interesting things. My IVIG gets boosted every 4 months with a 2 gram per kilogram dose.
Yeah, I was going to say that's one way to do it, is to just increase the baseline IVIG dosing in you to a monthly higher dose, or to more. Well, you were getting it monthly though before though, right?
Yeah,
a gram per kilogram.
I was getting 6 grams per kilogram from my PI. And then 6 milligrams per kilogram, sorry.
No, 6 milligrams. That's 400 milligrams per kilogram is a maintenance dose, right?
But because of my severity with my PI, we went to 600 instead of 400.
Okay.
So it's on a higher scale.
Yeah, got it. But
600 milligrams.
But that's 600 milligrams. So that's because a gram per kilogram 2 times a month, usually the max dose.
Yeah.
I mean, so one option then is, if the disease is still active, is to bump it more to the maximum immunomodulatory dose that we use for dermatomyositis, and that's the 1 gram per kilogram on 2 consecutive days on a monthly basis. That's the one option. And the other one is that if you still have a problem after that, is you may have to add another immune suppressive agent to the mix, and they have to. I mean, you should be okay from an infection perspective, but you're at higher risk because of the underlying immunodeficiency, but you're protected by the gamma globulin.
Correct. The problem is they can't do any testing on me other than symptomatic, and how I'm doing.
Well, I mean, CPK doesn't mean, just because you have the immunodeficiency doesn't mean it can't monitor CK. There's no other reason to check antibodies in you. I mean, if your body is making an abnormal autoantibody, and it may still supersede that, although I don't know about Jo1 positivity and primary immunodeficiency if they manifest the antibody, but I don't think that, monitoring your disease, looking at CK doesn't have anything to do with the immunodeficiency. You can still be able to mount an elevated CK, even though like we said earlier, dermatomyositis patients may have very active disease and have a normal CK even in the regular population. So that may not just be a good marker for you. And it may be looking at markers like MRI to see if there's inflammation in muscle tissue, or if you have skin, is there a skin rash? They're going to have to look at different markers of disease activity in you. But just because you have PI doesn't mean they can't look at the CK.
So that's the invasive part of it at this point in time. Is MRI is no big deal, but skin biopsies about every 6 months to monitor, because they can't do it with the CPK and analytes being normal.
Okay.
So I was curious if you had other things that you have done with your patients.
No, I can't say that I have a lot of experience, nor I'm sure anybody has that type of experience of following primary immunodeficiency patients over time in such instances. But I would, what is it that bothers you the most? Is it the weakness? Is it rash?
It's mostly the weakness, but I'm flaring with the rash now, so it comes and goes. We're trying to stay off of the high dose immunosuppressive drugs as much as possible.
Sure, makes sense. But I guess what I'm saying is, if somebody's going to make a decision to treat your muscle weakness, they better make doggone sure that it's associated with disease activity and not related to some other non-inflammatory mechanism. Do you see what I'm saying?
Yeah, I do.
Okay.
Thank you.
Yep. Yes,
Hi,
ma'am.
Dr. Oddis.
We got time for one more, so this is the last question.
Okay.
Thank you, Dr. Oddis, for everything you do.
Mm-hmm.
I'm I'm presently told I'm in remission. I'm just on Imuron now, a wean dose of 50 milligrams from 100. And I was on as highest doses of 40 milligrams of prednisone when they initially happened. I have polymyositis, anti-SRP, as well as necrotizing myopathy. So, great. Thank you, Lord. But my question is, I asked my rheumatologist, if I were going to have a relapse, what would you do? He said he'd put me back on a prednisone. But based on Dr. Venkowski's discussion, he asked me, do you think prednisone really helped me? And I think, I honestly don't think it did.
Rituximab.
I think it was you'd put me on rituximab? Okay.
Yep.
That was my question. Do you jump around IVIG?
Well, I just think that there's data out there on anti-SRP. I mean, I know about anti-SRP. We published one of the early articles on that with one of our fellows at Pitt. And we've also looked at that in patients in the rituximab study. Okay. And the Hopkins group has also published on that. And I think that a medication that has worked in patients who have SRP positivity is rituximab.
Thank you so much.
And I think it works better than prednisone. And what else did you have besides prednisone?
Imuron. But they weaned me off from 100.
Yeah, and it may have trouble getting it covered, but I would push hard. And there's actually, the good thing about it is that there's, like I put up the literature, there's actually published articles on using rituximab specifically in anti-SRP positive patients.
Thank you.
And if your doctor emails me, I can send them the information. Where are you from?
I'm from San Francisco.
San Francisco.
And my doctor
That's in the United States, right?
Yes, California. But he has actually his group of doctors is 2 associate professors at UCSF.
Yeah.
And I'll certainly show the
I'm
documentation.
sure I know the guys. Yeah.
Thank you.
Sure.
Dixon, thank you so much.
You bet.
We want to thank Doctor for a great presentation.
Okay. Well, thank you. Your questions were terrific. We wish we had more time, but we don't have to catch planes. So thanks for coming, and we'll see you next year.